felt like could just be a blip, 3 to 6 months, is turning into a long-term issue. And reimbursement notwithstanding, virtual healthcare is here to stay. So will we go back to healthcare pre-2020 ever? What technologies are available and what's coming to support remote healthcare? What will healthcare's built environment look like 5, 10, 20 years from now? And what are the hurdles and obstacles that are facing healthcare providers in this brand new environment? So we have an absolutely fantastic panel with a completely wide range of diverse backgrounds who's going to try and answer these questions. And so now it's time to meet that panel. Dr. Schwam, if you could introduce yourself, please.
Sure. Thanks again, Phil, for having me here, and to the AIA. My name is Dr. Lee Schwam. I'm a stroke neurologist by training, so I've studied the brain for 25 years. I've been very deeply involved in digital health and telemedicine, now what we call virtual care, where I lead the efforts at the Mass General Brigham Health System, where we just completed 1.2 million virtual visits since the start of the pandemic.
Wow. Wow, that's amazing. Thank you, Dr. Schwam. Lee, if you could follow on.
I'm Lee too, as known around when I'm with Dr. Schwam. Lee Shapiro, I'm co-founder and managing partner of Seven Wire Ventures. I also am the chief financial officer of Livongo Health, which has a pending merger with Teladoc that should be concluded in the coming months. I've been investing in the healthcare technology space for close to 25 years and have been involved in some of the new and emerging technologies that we'll talk a lot more about today. So thank you for inviting me, Phil, and the AIA.
Super. Thank you, Lee. It's great to have you here. John.
Yeah, hi. John Madison. It's a pleasure to be here. I was, for most of my career, the Chief Medical Information Officer at Kaiser Permanente, led the digital transformation, the deployment of Epic, also led our national virtual care initiative for the first 6-7 years. And we went from 50,000 visits a month in January to 50,000 virtual visits a day by June. And we also pioneered e-visits, over 5,000 a day in e-visits. We have multiple channels open for virtual care. And I'm very excited about what the future has to bring. I am Chief Medical Information Officer and operating partner at Arsenal Capital in New York.
Fantastic. Thank you, John. And last but not least, Adnan.
Hi, Phil and everybody. Adnan Hamid, I'm a healthcare CIO. Formerly, I was the Vice President CIO at Good Samaritan Hospital in downtown Los Angeles. Been working with community-based hospitals for over 20 years and worked with Phil and his team on the design of a new patient tower and sort of the planning and the execution and installation of technology in a 2019 building. So again, it's a pleasure to be and a privilege to be part of this panel. Thank you.
Fantastic.
Thank you all for joining us.
Okay, so let's dive right into it. And we're going to talk about the future, but we should really start by talking about what's going on today. And so I'm going to go straight to Dr. Schwam as a practitioner, someone who's doing this right now. Mass General Brigham is a leader in telehealth. Tell us about what you're doing, what the best practices are that you've found in this entire process, and most importantly, what the lessons learned from doing this and how we should all be planning for the future.
Well, thanks, Phil. I'll just make a couple of overview comments. First, we were doing a fair amount of telehealth in what I would say was pretty much a boutique experience. We had early adopters. We were just starting to think about how we might scale. We had very robust implementation of Epic, so we had a lot of transactions going on that were asynchronous, e-visits, e-consults, and patient exchanges, but we tend to focus our attention and our energy around the synchronous transactions and remote monitoring and those kind of activities. We were at 0.2% of all ambulatory care being delivered virtually pre-COVID, and we peaked at 62% as a system and 80% at the Mass General. And if you look at the curves, they just reverse each other. The ambulatory care goes like this. It falls off the shelf, and then it comes back again about 3 months later, and virtual care does the opposite. But it doesn't go back to zero. It's stabilized out at about 25%. 25% of a health system's delivery model being virtual-enabled video or audio care is pretty substantial. You know, that's a major business line. And so it has really required us to rethink everything. Anything you think of that you would touch as part of the value chain for in-person care, we've had to re-engineer for virtual care. And I think we've learned a couple of things. Number one, when in-person care is a viable option, people were very skeptical. A lot of our providers, it's not for me. I can't do it. My specialty, it's not appropriate. It'll never happen. Those are the same people banging down our door when in-person care was halted. So the pandemic accelerated virtual care partly because of the benefits of reducing the risks of infection. But from a mandatory perspective, it was that or nothing. And that really drove adoption very hard. We also had institutional buy-in in a way we've never had before. There was very little consensus. There was very little matrix decision-making. There was an incident command structure that meant we could launch things very nimbly. And that's had a profound impact on our organization. When we realized what we could do in a crisis, people have really been rethinking how we ought to be organized and how we ought to make decisions in the future. I think the last thing is it's opened up a whole new ripe area for thoughtful people and scholarly work, which is what care is appropriate for a virtual encounter? How can we deconstruct the in-person encounter, disseminate the component parts, and reassemble them, sometimes over a period of time? Get your labs first, get your blood pressure second, and then third, you have your virtual encounter with your doctor. I think this is going to drive a whole new way we think about personalized medicine, where we assemble information and data about patients through monitors, passive and active, through various predictive algorithms, and then create healthcare encounters with them driven by the disease pathology and the sensors, and moving away from the scheduled 3-month, 6-month, 12-month follow-up sequence. Let me stop there.
That was great. Would you care to posit what you think the actual, which are the ones, which are the treatments, which of the parts of healthcare work best for this virtual healthcare, and which ones less so?
Yeah, so I would say the cognitive elements of care are ideally suited. So the times you would spend with your doctor or your nurse practitioner or your speech therapist talking through risks, benefits, important decisions, monitoring progress, those things work really well in a face-to-face video environment, or even sometimes audio only for our patients with equity challenges, health equity challenges. And so a visit with the neurologist for many situations might be 90% or 95% of what needs to be accomplished is ideal for that. But even the surgeon who's doing an exquisitely complex surgery still has elements of their follow-up care that are cognitive, even so for the procedural specialist. So the key is, can you take those pieces out? Can you batch them together so that you can construct a meaningful use of someone's time spent on cognitive focus, split out from procedural focuses?
Fascinating. Thank you, Lee. And John, welcome back. Perfect timing. I was going to punt to you and say, so Kaiser could be considered one of the absolute leaders, was doing a lot of telehealth before COVID even hit, and you had a massive component to that. Can you talk about that from a Kaiser perspective? How well Kaiser was positioned before COVID hit, and if you think they had to make any changes once that happened?
Yeah, I'd like to tie a couple of Lee's comments together with the answer to your question. The first thing is that I've been bristling at the meme of patient-centric for many, many years, because patient-centric is an oxymoron. Patients are what doctors call people. And so what we've seen in healthcare to this point in time is largely, how do I develop a healthcare system that treats a community and maximizes either revenue or reduces cost or some combination of that, as opposed to taking the person-centric view. And this is not in any way criticizing what Lee had just said. It's just in addition to it, we need to rethink what the world looks like from the perspective of being a whole person that, as one of our life experiences, needs to access healthcare, as opposed to the perspective of a healthcare system. Wow, I've got all these doctors and nurses and pharmacists and facilities and labs, and how do I adapt to the COVID world and implement this new technology called virtual care? You really need to flip that into the human-centered design model. And I think that there's a huge opportunity there. So one of the reasons that I worked for most of my career at Kaiser Permanente is because one of our founding fathers, Sidney Garfield, I like to refer to as the Steve Jobs of healthcare, because he imagined comprehensive prepaid care that focuses on value-based care over 70 years ago. He published an article in Scientific American in 1970, 50 years ago, looking at how integrated technology systems can better support integrated care across all venues of care. And we are still standing on his very tall and broad shoulders and executing to that. So because of our value-based care model, we were well positioned long before COVID to do what made the most sense in terms of quality outcomes, cost outcomes, and so forth at Kaiser Permanente. And so in that context, it was much easier for us to do the right thing from a human perspective, from the person-centric care perspective, as opposed to a patient care perspective, which puts the whole person into a tiny box called patient, and same for consumer-centric care, consumers of healthcare. So the bottom line to answer your question is that we were way far ahead of the curve before COVID and quickly scaled because we built. One of my mantras has always been, don't start a project that doesn't have scalability built into the architecture early. And so we architected for scale very early, and we're able to very rapidly scale from the 50,000 visits a month in January to 50,000 visits a day, and right on down the list of virtual care. In that vein, as we imagine the future of where we're headed, we really need to look at it from the perspective of, rather than what do I do with all these doctors and facilities and procedures and analytics and cognitive services, what do people really want from first principles? And what you find is that there are seniors today who have been described as technically challenged, which they're not, who are telling their neighbors, oh, I just had 2 virtual visits with my doctor. It was amazing. I didn't have to hop in my car and find a parking spot and go through registration and wait in line. I got everything I needed online. And the neighbor thinking, well, why doesn't my doctor have that? So I think we're going to see if you will, a consumer-driven drive for more and more and more virtual care. Obviously, not every procedure lends itself to a virtual visit, and there will still be the need for facility-based care, no question. But to the extent that convenience drives decisions, and to the extent that reimbursement models support that convenience and don't undermine the revenue stream, I think we're fine. The last thing I'll just comment on is the concept of cross-product price elasticity, which refers to the fact that if you have 2 products that address the same problem, the price elasticity depends upon the penetration and the acceptance of the other product. So if you compare virtual care with in-office care, they're really 2 very different products with 2 very different characteristics. And to the extent that reimbursement models make little distinction to a virtual visit versus an inpatient visit, with a fully burdened cost of an in-person visit much higher, we will, to the extent that there's parity, we will see a continued, sustained, and rising shift into the virtual care space. To the extent that facility fees and fully burdened costs and overhead are built into the reimbursement and fee schedules, we will see the retardation of that evolution.
Thank you, John. I'm going to pivot a little bit now because I want to ask Lee, who is our medical device guru, about how we're going to facilitate all this stuff at home. I mean, we heard from Ron Galloway this morning about smartwatches and monitoring at home and all that kind of stuff, but there's a huge amount of extra things which go on and could go on at home. And Lee, you and I were talking about, it goes beyond monitoring to imaging and procedures and lab testing, all those kind of things. So tell us what's coming.
Well, thank you, Phil. And I just would like to, as kind of I transitioned to answering your question, there were a couple of comments that Dr. Schwam and John had made that I think are really important in terms of thinking about how this will evolve and what we'll see coming in response to the question you asked. And I think that it's more than just the cognitive piece of care. We we have built a healthcare system that is great at fixing broken arms and great at providing procedures, but yet we're not dealing with the leading cause of disease and death for so many, which is chronic conditions. And when you think about, aside from the communicable disease that we're all worried about and why we're on Zoom and not together for this conference face to face, even then, considering that, when you look at heart disease and complications from diabetes, those are the leading cause of death of those of us here in the United States today. And so to manage those types of conditions, unless you happen to be married to a great physician like Dr. Schwam, you're not going to get 24/7 care. And so what we need,
My wife doesn't get 24/7 care.
and so you need to be in a position where you can provide the ability to support individuals on their care journey. Now, shift to what John had said about the focus on the whole person. I am not a diabetic. I am not a hypertensive. I am a person who happens to have a disease, and language really matters. We invest in what we call, in companies that support something we call the informed and connected health consumer. No one who is on this panel and no one in the audience watching us wants to be a patient today, but every one of us wants to be healthy. And so what we aspire to do is put our disease in the background. So let's put that in the context of the question you asked, which is what's coming. Well, the video visit, I can certainly look at John and see that his color looks good and he looks pretty healthy to me, and I can ask him to stick out his tongue, but there's not very much that I can do in terms of a physical exam through a video visit. But if we were in a position, as Ron was mentioning earlier today, about having biometric devices that capture data in both an active and a passive fashion. So what can I monitor about someone's movement in the home? What can I monitor with regard to how they're using their phone? What is it that I can start to capture inside where they are? Home, car, office, when we go back to offices, that allows me to have a better picture of someone's health. And I think that we're starting to see the convenience, not only of things like home medication delivery, but personalized, directed home testing devices. There's a number of companies that are providing diagnostics for use at home that will provide the ability to allow us to analyze and understand where someone is on their health journey and better inform the visit. Prior to my going to see any of the providers that I work with, I ask them to do my diagnostics in advance of the visit. And the reason is I don't want to walk in and say, here's what's wrong with me, and they treat the symptom. What I want to do is understand the cause. And so the more of that data that we can provide to inform the physician-patient encounter, the better off those decisions are going to be for when you do have to go into an office or you do have to go to a facility. So I think that what else is coming in this regard? I've been amazed at some of the advances that have occurred to date because of the pandemic. And we're learning things that allow us to have better diagnostic tools at home and better self-care tools to treat the whole person that John so eloquently described.
What about that next level beyond that? You know, we can look at each other on the screen. You can do an EKG from a smartwatch. What about being able to do testing from home, lab testing or imaging? Or what about even, is there a way to do procedures in a remote visit?
Yeah,
so go ahead, John. No, go ahead, John.
So as Lee Shapiro alluded to, there are a number of companies like You Do Test, where their whole business model is how you provide in-home testing on a very rapid turnaround basis without having to go into a facility. And we're seeing these devices. So unfortunately, Theranos poisoned the waters from the investment community for a long time to come over some very shady practices. But in fact, the vision is alive and well, and there are companies that are beginning to execute with very low cost diagnostics, being very rapid turnaround to the home. And so if you look at it from a person-centric point of view, and look at what are the possibilities, not only for the biometric monitoring, but for on-demand specific tests in the home. You see that there is a very, very bright future for moving more and more of the services that are currently required to be face-to-face into the home and workspace environment. And then if you realize that after COVID, we will see a return, not a full return, but a return of many people, working in facilities. There's a population density associated with work sites that are going to really amplify the virtue of these worksite related, virtual care booths that can include a lot of infrastructure that you don't want to build necessarily into every single home, but for 50, 60 employees or more, make a lot of sense. Those kind of virtual visits can be augmented dramatically with any number of diagnostics. In terms of procedural things at home, as Lee just referred to, we know that the drivers of health are much more associated with lifestyle decisions than they are with drugs or hospitals or clinics, and how you eat, sleep, socialize, and exercise. The blue zones being the original masterpiece on the epidemiology of how healthy lifestyle leads to population health and longevity at scale. There's a lot of what we can do without to prevent the need for procedures absent trauma and the things that orthopedists do. So we're going to see a shift from, as Lee accurately described, from disease care to true health care. And I think that we're going to be able to reduce the demand on procedural services based upon reducing the lifestyle decisions that people have made in the last 100 years or so that are counter to living a long, healthy life. So there's a lot of interventions that can be reinforced through behavioral and motivational sciences to get people to do those things that reduce their disease burden and prevent it, ideally, in the first place.
So, Phil, can I just jump in just for 1 second? Because I think we also have to agree with everything that John and Lee have said. But I do think we also have to remember there's an importance of space and what is the built environment at home like, and not all of us work in a workplace that is amenable to serving our healthcare needs. And we have many patients in our health system, certainly, and I know where John used to work, who are low-income wage workers. They may not have Wi-Fi at home. Many, but not all, have a smartphone. They don't have a place at home from which they can conduct these visits. There's a lot of, it's really important as we deconstruct and reconstruct this care and we build this, I would say, rather than thinking about it as home-based, it is truly person-centric. And for many people, home is the centric place they want to consume this experience from. But for others, it will be public spaces, it will be workspaces, it will be the need for us to reconceptualize some of the spaces that we've had as civic arenas. I don't mean football stadiums, but the public library. People don't go to public libraries anymore, yet we have them in every city, and we have many of them actually in many cities. Why couldn't that be retrofitted into a space in which healthcare could be consumed virtually? So I just think we have to remember to think very broadly about space when we talk about and think about this person-centric transformation. The last thing I'll say is I heard a great quote from one of the people in at my hospital who was talking about patient-centered care and basically said, it's really hard to put the patient in the center if the doctor's already there. So, we really have to think about moving aside.
I love that. It's a really good point. And I think we're learning a lot of lessons also from people having to learn from home. Tele-education has a lot of those same issues of patient privacy. And so, Adnan, I'm going to bring you into the conversation because
Bill,
I was
just going to make sure though that I added a couple of thoughts that might be interesting here. One, there are certain things that we might conceive of as only being available today in a hospital, and yet there are companies that have been partnering with hospitals to deliver what's called hospital at home.
Yeah.
And so when you start thinking about need for infusion services, for example, it used to be that a patient would need to go in and sit for 8 hours at a time after waiting in a room filled with other patients and get infusion in that type of environment. Now there's infusion services at home. There's other post-operation recovery that's at home where literally they're going in, and if you don't have the right resources there, they can set up the appropriate facilities to be available at home. There are a number of companies that are doing home visits again. So I'll date myself. Dr. Welby is coming back and making house calls. And literally where we're leveraging our emergency medical services teams that are going out and instead of just responding to kind of someone who needs to be brought in because they're having, after a slip and fall or a cardiac event, brought into the hospital, they're going out and making preventative health visits into the home and bringing with them some of the tools that they need because they won't be available in every location. So we're starting to see some of that as well. Lastly, there's a company called Higi that has 11,000 locations around the country. Last year, before the pandemic, they saw just under 100 million visits to these kiosks that are located in retail facilities like pharmacies and food stores. They're office-based. They're also in shelters where individuals who don't have housing are living, to provide opportunities for individuals to have their blood pressure, their weight, and other vital signs captured and then shared with a clinician to be able to do that in a remote form. So there's a number of different modalities that are now, I think, coming to the forefront in light of the pandemic.
Brilliant. Thank you. Thank you.
Sorry for interrupting.
I need to bring you into this now because you're our CIO, so you're kind of a shepherd for the data that the hospital is collecting for everybody. So I have two questions for you. The first one is, how do you deal with all these people coming in and saying, oh, look, my watch is telling, my phone is saying this, my watch is telling me this? How do you make sure that the patient privacy is maintained and all these kind of things? And then secondly, how does that pivot to physical buildings? And because that's something we really want to talk about in this panel, is what is that really going to mean from a built environment perspective, and how are we going to adapt and have to respond? So tell me.
Again, thanks, Phil. So kind of answering the first question, privacy and security. So there's two aspects. One is just basic user understanding of privacy and security, user awareness of the data that we're exchanging, and make sure that that is kept in confidence. So that's really human engineering. And two, obviously you can associate that with a lot of the technical security, the technology that's out there that can help with securing devices on networks that are active in passing that data. So it is a bit of both, but again, it comes down to the human and making sure that they're aware of the data that they're obviously passing through the systems. Now, you're right. So kind of segueing to the healthcare facilities, and so Phil, the story that comes to my mind is, when we were working together back 5-6 years ago in the planning of the patient tower for Henry Mayo Newhall Hospital, the biggest question was, how do we, knowing that hospitals building constructions are very long in timelines, that we would be opening up we're planning for a building in 2014, knowing that we're going to be opening up this building in 2019 and avoiding putting 24 technology in a 2019 building, right? And so how do you do that? Because let's just kind of put in perspective, in 2014, the iPhone 5C was coming out at that time, right? So now if you punt forward to 2019, you're talking about the iPhone 11, and there is huge technology advances in just that device. And so as we were planning for the tower, you really got to just keep it simple, right? That's really the acronym. We knew that going into building that facility that we would need to make sure that wireless and access to not only the internet, but really just the coverage of wireless was spot on, right? We could not have an excuse for dead zones in a building. So that was one key area. So we really wanted to make sure that we were as best as we could, making sure that that was available. Power. These devices are going to need power, whether it's in the patient room or at the nurse's station or for physicians and everyone. So what we didn't want is someone sitting in the hallway, like we see at airports where they're just hovering over outlets and trying to charge their devices. So we want to make sure that was the case. And then third, really treat the internet as a utility. It's very much like water and electricity and gas. So utilize the infrastructure in the buildings to develop redundancy, so that, again, even though we were connecting to the data center in a different building, that we were creating paths to the internet so that if there was ever a major interruption in internet, that we could still provide the technology and application services, not only just to that building, but throughout the campus. So I think you really just have to elevate the use of technology and applications, and understand that people are now can't really be in a downtime where they're on paper anymore, right? We've just got to move on from the aspect that people are used to and want access to electronic data, and that's how they're making real-time decisions. And knowing that even the care of patients, right? So that when doctors are not spending time in front of a computer, but hopefully speaking to the patient, and a lot of that language is being captured through AI and machine learning, so that less time is spent in front of a screen and more time in front of the patient.
John, you have a comment on this?
Yeah, let me make sure I'm off mute. Yeah, I'm off mute. So I just wanted to draw a linkage between your question around facilities and the role of data and analytics. And I think the thing that's easily overlooked here is the fact that there's an unknown unknown. And as Ron Galloway said in his brilliant keynote that preceded us, predicting the future is really difficult in healthcare because of all of the three body problems and the embedded three body problems that he characterized so brilliantly. What I'd like to say is there's three elements to sort of mitigate the difficulty in planning new facilities vis-a-vis the difficulty in predicting all of these three body problems and where they're headed. So the first is we need to have evidence-based digital medicine. So evidence-based clinical medicine is pretty well advanced. But evidence-based digital medicine is lacking in the following ways. A whole lot of virtual care that's delivered today is open loop. So a physician will have a video visit, order some tests, maybe a referral, maybe some imaging, and then somebody else follows up. So they don't have the benefit of an adaptive learning system to really constantly manage that curve. And specifically, with the problem of the unknown unknown, how do we prospectively identify someone whose known past medical history and whose current complaints introduce enough of an unknown unknown where they should be triaged to, through intelligent routing based upon machine learning and evidence basis, to a face-to-face encounter simply because we don't have the confidence bounds around treating that complaint in the context of that constellation of clinical problems in ways that we can have confidence. So identifying the unknown unknown and directing people to a facility in that context is one of the great frontiers of data and analytics. The last thing I'll say in that regard, and keying off of some of Adnan's great observations, is that all of this streaming data from the biometrics and the wearables and the watches and the iPods and the earbuds and so forth, that is going to be coming forward. Doctors are already totally inundated. If you ask a doctor, would you like more data? You will get about 95% of them saying, please, I don't want another shred of data. Give me actionable information. Give me summary information that's visualized in a way where I can go one click to decision based upon informed options. And so we're speaking today, we're still kind of stuck in this conundrum of how do we get all the data we need to make the right decision. We're going to move past that very quickly, and it's going to be how do we visualize the data in ways that make it easily actionable. And that is the future of decision making in healthcare, where the healthcare provider is directly involved as opposed to an algorithm. And so to the extent that we can implement those kinds of evidence-based digital medicine support, and to the extent that we know where there's enough of an unknown unknown to say, you know what, you need to see somebody, they need to be in the same room with you, there are intangible things, and to the extent that we're seeing massive epidemics of anxiety and depression and behavioral health issues associated with COVID, this was on top of a pre-existing epidemic of anxiety and depression. We need to have tight integration of evidence-based practices and behavioral health linked to the traditional biological health aspects in ways that help us know, you know what, this person really needs someone to show some empathy face to face. This person really needs to experience the caring of a health care system towards their health and not just an algorithmic driven decision process. So I think that there's a huge future for the analytics that encompass the unknown, that intelligently route people to a face-to-face when appropriate. And what's going to happen, as with Clay Kirshensen's construct of democratization of services, when you need the expert, that expert is going to need a much higher level of capabilities than what the person can get at home, or they already would have solved their own problem at home. So I think we're going to see, similar to what Ron Galloway was saying about hospitals this morning, that we're seeing more less hospitals overall, but more micro hospitals, and we're seeing the big institutional hospitals get bigger. I think we're going to see the home, and as Dr. Schramm so eloquently articulated, wherever the person is, being the site of care for so much of it. But when they need a face-to-face, it's going to be more like a micro hospital kind of situation than it has been previously. And so the last thing I'll say is, and this is to Dr. Schramm's comment, about 20 years ago, I rejected the notion of a cell phone being a mobile device. It's the most stationary device on the planet because it's attached to us wherever we go. And so I think that when we start looking at the accessibility of a smartphone and a wireless connection, and we see the evolution of satellite-based bandwidth, we're going to see pervasive bandwidth, and the consumerization and the plummeting costs of a smartphone are going to overcome a lot of those issues. And I think there's a lot of policy that can be brought forward by the FCC and others in terms of how we ensure that basic services of bandwidth and smartphones is part of a healthcare portfolio.
Hey, so Phil, if I can add just a comment, echo Dr. Madison's just thought. You know, one of the things also when we were designing the tower was, given the COVID pandemic, is that I know that the hospital was able to rearrange the space in a very quick manner, where a med-surg floor or a post-surgical wing was converted very quickly into a COVID specific area. And the way that what you have to make sure is that technology is not the barrier, and when you have to switch it, that you have to make sure that the technology is adaptable, so that when you do make the switch in services, that it does not impede the ability for the business to make that decision. And so you really got to keep things neutral. Again, back to Wi-Fi. So I know that specifically, the hospital was able to reconfigure the wing, but also given that we were now restricting visitors to come to the hospital to see their loved ones, really make sure that video conferencing, whether it's just basic FaceTime through an iPad, that we were able to make sure that those experiences were not impacted, right? Because back to the patient experience and back to the families as they were trying to figure out what was going on, that the technology enabled a better experience for everyone through the pandemic. So again, keep it simple.
That's a really important point. And Phil, maybe I'd like to just draw on a theme that emerged in this last part of the conversation, which is really about the humanization or dehumanization of the medical experience. And there's a lot of anxiety that robots will replace people, and that I'll get just an endless phone tree instead of an encounter with a physician. And I think there are, and even just in the point that Adnan just made, having the ability to look at your healthcare worker or your family member face to face, no mask, no gown, no face shield, is a much more human interaction. Even though it's happening on a piece of titanium, it's much more human than a nurse coming into your room to talk to you muffled through a mask and unable to read their facial expressions. I think it's an interesting question of whether we can through human-centered design, use the AI, the machine learning, the conversational AI components, the digital navigation to improve the personal feeling of the experience. We I think, as physicians, are overly value the time the patient spends with us, and we believe that we're delivering a highly personalized experience. But when you think about the journey from the traffic, the parking lot, the rude parking lot attendant, the difficult physical navigation, the line at the cafeteria, that we don't take cash, we only take credit card, it's actually a very dehumanizing experience, even though it's in person. So I think dealing with that head on, recognizing that that is a concern of patients, and using the information we have about people to create a warm and very personal experience while guarding their privacy, with utmost meticulous detail. In my mind, it's the combination of Marcus Welby and what happens when I go on Amazon, where Amazon tells me, someone like you, Lee, I bet you'd be interested in this deal on, on these wireless headphones, because it's Amazon Prime Day, it's a 20% off, and I know you like these kind of things. It's not uncanny valley, right? It's not intrusive, but it feels like, hey, they know me. Like if I went to the record store and the guy said, oh, there's a great new record out, I think you'd like it because he knows my taste. So personalizing the experience and using technology in the background, simplifying the user experience, moving all the complexity back into the wall of the machine, I think can be really valuable. And John was briefly alluding to these kiosks, workplace kiosks as a place to engage healthcare. No better place to engage many of your low-income workers with the healthcare, not just a screening, but intervention for blood pressure, than right outside the cafeteria, right? Private spaces, easily accessible, don't have to take time off from work to go. I think there's a lot we could do to make the healthcare experience feel much more personal for people who are used to getting their healthcare, quote unquote, in person.
Thank you, Dr. Schwamm. Scott, did you have a question?
Well, I did, and I think it's almost like the white elephant in the room. And we're talking about all the data and all the information that's coming in from devices, and whether they be kiosks or wearables or cell phone connections and things like that. What about the underprivileged? What about the rural areas? What about those areas that don't have that access? I think, in terms of what's going on with teaching right now and having kids being taught virtually at home, and, my wife is a teacher, and half of her kids don't have enough broadband width to maintain a video link. It's a huge challenge for that. And even though a lot of this data and a lot of what we're, developing these things off of is those of us that can have a wearable device or have a cell phone, how are we going to expand this whole concept of delivery to those areas that are so much more challenged? And then on top of that, we also do the at-home care when, probably everybody on the screen right now, and probably most of the people that are listening in, their homes are pretty clean. Well, I guarantee you there's a lot of homes out there that you don't want to be doing patient care in their homes. There's a lot of conditions out there. Then how do you work with those challenges and move beyond that as part of this deliverable?
Well, I think this is a critical. This is when people talk about structural racism and structural inequities in healthcare, you put your finger right on it. In 1930s, there was a similar dilemma with electricity, right? The cities had electricity, and with that came all sorts of goods and services and quality of life, and eventually things you can't live without. And I think we're at the brink of broadband being a fundamental right, like clean municipal water supply and electricity. So there's definitely a huge risk of excluding large areas of the country that are rural and that have inadequate broadband, much more so than, as John alluded to, the elderly who are somehow digitally incompetent. That's just bad UI. People aren't incompetent. It means that the user experience is just terrible. So I think you're right. And in our gold rush to build this hybrid network between healthcare systems and consumer grade, not medical grade, consumer grade devices. You're right. Patients want to send me all sorts of data. They want to send me data about their mattress pad that now can say how they positioned during sleep and what the quality of their sleep was. Most of this is not validated. There's the digital evidence-based medicine piece is really lacking, and those companies are piggybacking on and hijacking the low-cost consumer threshold for releasing a product into the world, which is really just about safety and that you won't get electrocuted or swallow it, with medical grade demonstrating efficacy and reliability of signal processing. So the market's being flooded with the equivalent of digital nutraceuticals with all sorts of claims about how they can help improve your life and your health. And we're leaving, in the meantime, an enormous chunk of people in the country out of this revolution of truly patient-centered care. So I think this is a huge policy issue. This comes down to things like John was referring to, if you pay the same for digital as you pay for in-person, you're going to drive adoption through the roof. If you discount the payment for an audio-only visit compared to a video, you will have baked structural inequity into the payment system, which means it'll be there until the next payment reform. So we must tread carefully, or we're at risk of disenfranchising an enormous number of people who won't have the benefits of truly effective preventive care like Lee's interaction is providing. So, I'm in the Livongo program and I'm getting my diabetes managed tighter than a drum. My the buddy I work with who doesn't have that, he's fallen through the cracks. And the only difference is really I've got a plan that gives me access to devices and broadband and all that, and he doesn't. That's not good enough.
That's right.
So if I could just piggyback with Dr. Schwemm's remarks, yes, broadband's got to become a utility, just like power and water and gas. In my sort of travels pre-pandemic globally, third world countries are able to build up the infrastructure at a faster pace. You will go to a rural village and they will have a mobile device to be able to do financial transactions. And so I know it's possible. If it's possible there, I know it's possible here. I think it's just got to have the right focus, and the infrastructure just has to just meet the needs of the community.
There's work on this underway. In August, there was an executive order signed that promoted activities by both the FCC to expand broadband access as well as the Department of Agriculture. There's been legislation introduced in Congress to also provide for greater high-speed access into both rural and underserved communities. And then there's efforts that are being undertaken by organizations that are traditional telecom providers. The T-Mobile 10 million plan, some of you may have seen ads for it in terms of delivery of better broadband access into 10 million homes. Comcast has efforts underway. Facebook is working on programs. Google with their balloons that are going to be able to provide internet access into communities that don't have them. And then John mentioned some of the satellite activities, including the work that I think was just undertaken to launch 60 satellites just in the past few weeks that are microsatellites that are going to be able to provide better transmission of high-speed internet services into more parts of the world. So it's a U.S. problem, certainly. It's a global problem, but there's a lot of folks who are working on addressing it, and I'm hopeful that we'll see progress based on some of those activities that have been undertaken.
If I could just add one brief thing, I agree 100% with what's been said. The thing I would add is that the complexity of the third body problem and everything in healthcare is pervasive, as so well characterized by Ron earlier today. There is a global, it's very hard to predict the future, but there's some global levers to pull. And the biggest global lever to be pulled, since we get what we incentivize, is to move in the direction of value-based care. Because in the value-based care model, you can do what's best across the key parameters of quality, cost, service, and accessibility without regard for, am I going to get paid more if I do a virtual visit versus doing an in-person visit versus doing a procedure or not? And so to the extent that it's evidence-based outcomes that are borne, that's risk sharing, borne by the providers and the insurers, we can overcome a lot of that complexity, allow the people who are directly involved, those individuals seeking health, those individuals providing healthcare, allow them to figure out how to personalize it. We talk about precision medicine from a very technical scientific standpoint, but what we need is precision medicine, and we need precision health, which is a very different thing than precision medicine. And you cannot legislate something as complicated as all the third body problems associated with healthcare. And to the extent that we move to value-based care, the incentives align much more effectively.
You know, I just want to go back to something that was mentioned earlier, and I forget which of the panelists brought it up, but this, I think it was Lee, talking about, the non-communicable diseases. We've conquered, infectious disease. Now we got to conquer non-communicable disease. Well, the reality is that those diseases, though not infectious, are still highly contagious. And there's a lot of great work showing that our social networks influence our behavior in ways that are very hard for us to recognize and appreciate, although companies like Facebook and Apple and Google have figured out how to lever those to get us to behave in the ways they would like us to behave. I think we have to recognize that as we digitize, connect, and create these enormous capacities for online connectivity, we also run the risk of contagious outbreaks of unhealthy behavior. We certainly talk to any parent who has a child below the age of 10 and mention the word Fortnite, and you'll see the reaction. It's very hard to control the social influences of vulnerable people when you can't lock them, the unwanted influence outside the front door. And so I think we have to be very thoughtful along with this revolution in connectedness. We talked before among the panelists a little bit about, what's happening to brain development in the generation that is digital natives. And, clearly the environment influences our neuronal structure. We remodel our brains in response to the environment. We just need to be thoughtful about this. And we need to remember that the digital encounter may leave a patient with a very different feeling than the in-person or the direct interaction experience. So knowing that I'm being monitored day and night for my health may feel very differently than going to the doctor and hearing about my health and then not thinking about my health or my illness in a very explicit way. So there are psychological impacts of how we design the space and where people are experiencing this now, right? Phil, you look like you're working in your office, but plenty of my colleagues are working from their bedroom, right? I have a virtual visit or a meeting with them, and they're in the bedroom. How do you sleep at night when your office has now become your bedroom, right? How do you make a psychological distinction between those spaces so you can compartmentalize some of this work? And so as we instrument the home and instrument the person, there is a risk that we create an almost obsessive degree of attention to our health, our illness, our wellness, and that may not be productive. We don't know. We need to engage our psychologists, our sociologists, our anthropologists to really understand where our relationship to technology is healthy and where it's unhealthy.
May I ask a question? We do have some questions coming in, and we don't have a lot of time, so there are a few questions coming up, and one of them very quickly. You're touching on psychology and behavioral health, which has been a big part of our architectural endeavors lately because there is such a high demand for behavioral health facilities because of rising behavioral health problems and this recognition. And one question you're talking, so we know that virtual health is, or that telehealth is now being applied for psychiatric visits, psychological visits, I guess I'd say behavioral health visits. What about what you just said? How do you see this as a continuing trend, or do you see that it could potentially have a negative effect because you are not having face-to-face or human contact? Do you see this as growing virtually?
Yeah, I mean, one of the areas that was earliest to be reimbursed and has been recognized forever in this area is the suitability of behavioral health interventions for patients over video, over virtual care, in part because patients with behavioral health interventions are often visiting the doctor once a week or more frequently, and that's highly disruptive from a work perspective, if you have to take off, every afternoon on a Wednesday in order to go see your therapist. CBT, cognitive behavioral therapy, seems to lend itself extremely well to this kind of intervention, augmented by asynchronous interactions or application-based interactions. Think Headspace, Mindspace, that kind of thing. I think that there are patient-specific factors that drive whether or not this might be more efficacious than face-to-face in-person care or less. Some patients are more likely to confide challenging and difficult things when they're not in the same room with the other person. Patients with anxiety disorders or autism spectrum disorders who are very sensitive to stimuli have a hard time watching an emotional reaction to something they say, or they find it much more effective to be in their own protected, safe, alone environment interacting with other people. It's not complicated by the physical presence of another, which is so disturbing for them. So I think there are a lot of areas where this could be very helpful. But we do need to remember, and all of us are exquisitely aware of the element of physical presence and human warmth that one experiences sitting in the same room together, which is so different than over the video. And we need to learn how to project empathy and compassion in ways that feel over the top when you're on the other side of the screen, but to come across as warm and engaging. It's like being on stage, you have to project and overemphasize. We need to train our trainees. We need to train our providers on how to be good doctors and nurses and respiratory therapists over the internet. But fundamentally, I think we've got too many bottlenecks in the way. We need to consume much more healthcare, I think, not less, but different healthcare and better healthcare. And the way to connect people wherever they are geographically distributed with the providers, wherever they are much more concentrated, is fundamentally, it's a matching algorithm problem. And if you can divorce the need to be in the same space at the same time, you dramatically increase the access. So I think it's here to stay in behavioral health forever. It may even be the dominant player for a lot of behavioral health, certainly for private pay. I think it will be maybe 8-to-1, 10-to-1 ratio of over the internet, or online versus in person. But I think there's going to be a lot of work that needs to be done to show that the outcomes are similar. And that's very hard to do. It's hard to do with in-person care. No one has ever forced me to prove the value of a follow-up visit after a stroke with a neurologist. It's just accepted. But people want you to prove that the online visit after the stroke with a neurologist is of value, or they don't want to pay for it. So we really do need more of a reckoning, like John said, around value. What are we trying to get out of the system? And how will we be best positioned to add value? For behavioral health, the internet will give us the ability to give services to a 10x multiplier compared to what we do now, I think, in ways that will be very beneficial.
And if I could add to that very well articulated argument, the opportunity to use virtual behavioral health affords several things, one of which is load balancing. So there's been a lot of experimentation pre-COVID, pre-virtual, with embedding virtual behavioral health services in with primary care so that there's a more integrated, holistic approach. The problem with that is in smaller clinics, the load balancing of when is the behavioral person physically in the clinic and when are they available for a real-time kind of integrated team-based care. And in virtual care, you can do a warm transfer from someone you've seen in a virtual visit for diabetes and hypertension, which may in fact have more to do with the stresses that that person is confronting, particularly in the lower socioeconomic end of the spectrum, and particularly now with COVID, and do a warm handoff to a behavioral health person that's in a queue and available now. And so this problem of load balancing in the physical space is largely mitigated in the virtual space. And this applies most especially to behavioral health, but applies to every member of the healthcare team. What if, from the human-centered design perspective, you could get a visit that addressed all your needs in an appropriate succession with warm handoffs because of the load balancing that you can do with highly distributed resources available right where you are on a moment's notice. So I think that there are some extraordinary opportunities, as Lee alluded to do far better than we've done historically in the face-to-face. But the last thing I'll mention is there's a whole value chain, and this is something that's been very near and dear to my heart for decades, and I've spoken about the need to use modern technology to restore ancient wisdom and empathy. What if we look at what the physician and the healthcare delivery, delivering health rather than treating disease, what if we look at the whole selection process from the pre-medical years through medical school, through training, including virtual care training about how to project empathy in the virtual space? How do we select different people who are more adept at using visualization tools and reviewing options and delivering care in ways that free the time up of the visit, of the encounter, to be empathic and really understand what's motivating that individual and helping create a solution that is customized for them, and not just their physical needs, but their emotional and spiritual needs for that matter. So we have a whole new opportunity in the virtual space to do load balancing across all of those various services real time in ways that just are hard to replicate in the physical space.
Let me jump in, and just so we can get through our questions, here's another one. Because as architects, this group does a lot of upfront programming meetings with hospital providers. How should we start thinking about the impact of digital medicine, telemedicine, on the space needs? What are some of do you have questions that we should ask specifically? Are there particular areas of care, and I'm very interested also in Lee, what you have to say about chronic care, which is what Livongo is focusing on. And will these space needs in the hospitals be reduced? What are the questions we should ask, and should we start considering these as we plan, future healthcare facilities and clinics, hospitals, clinics?
Thanks, Meredith. Let me jump in and then open it up. My perspective, and it was alluded to earlier, it really starts with training. We need to be building the skills that are appropriate for our medical professionals in order to be able to adapt and interact in these new environments, and provide them with the space that's appropriate for the types of interactions that they're going to be having going forward. Oftentimes you find that someone's trying to conduct a video visit off their phone or an iPad, and that just might not be suitable. It might be convenient, but it might not be suitable in terms of being able to provide them with the right level of information they need for the type of visit that they're engaged in. So I think that space needs, if you think about it from the provider side, are going to evolve from the types of offices that they have available today, the exam rooms they have today, into rooms that are much more suitable for the types of virtual visits and the scaling that we need to have in terms of being able to provide that. Adnan mentioned before the importance of data. And when you think about managing a population of individuals and triaging those who need the right interaction at the right time, and helping to prioritize your time in terms of focusing on the hotspots in the population, there may be certain needs where you have to interact with someone virtually, others that might be able to be done through a chat communication, where you need certain capabilities to be able to broadcast that out. You might be sending video, and you need a different type of environment in terms of being able to record that appropriately. So I think that assessing and understanding the needs of our providers who are going to be interacting in these new methods is going to be important in terms of the types of questions you're going to ask and design of the facilities that they're going to be working from.
Yeah, I want to pick up on that because we're struggling with this right now. How do we use our existing ambulatory exam rooms? And quite frankly, before COVID, we were trying to figure this out, and we were doing virtual visits before COVID at a large scale in neurology. And the question comes up: well, should I use my clinic office for virtual visits and mix them in, interweave them with in-person? Or should I only do virtual visits in my administrative office if I have one? Because I don't really want you sitting in an expensive, 14 by 14 foot office, which has enough room to accommodate the patient and an exam table and a sink and another person. For a virtual visit, I want you in a cubby, basically. And so I think the exam room of the future either needs to be highly modularized, so you literally can like push a button and it gets smart, and the cone of silence comes down and the room divides into four, and four people can be in their kind of acoustically silenced cubicles doing virtual visits. Or I remember we were at the CES in Las Vegas, and they showed this beautiful wooden credenza, at the foot of the bed in this bedroom, and then you pushed a button and the TV came out of it. And my wife is like, "That's perfect. You get a TV, I get a credenza," right? We need the modern exam room to be a place that feels perfectly designed for in-person care and perfectly designed for virtual care, if you're going to try to combine them. And if you're not, then you need to think about duplicative spaces, or, like the old phone booths, that all the reporters would run to the minute the story broke. They'd all get on the phone and call in the line, the piece and their byline.
Yep.
You might need to think about cubes, really, that are private and soundproof and that are built into. They're outside the OR. They're in the hallways. They're in the places that the providers spend time, but need to step away to take a call. I don't know the answers to this, but we're struggling with this literally as we speak, because we're about to build a brand new hundreds of millions of dollars building to expand our inpatient space. And even there, the question is, what should the rooms look like? Where should we expect the doctors and other providers are going to be spending their time and be as accessible as possible?
So let me just kind of echo Dr. Schwamm's point, and maybe something with the attendees of architects, one of my sort of passions is, especially with the design of buildings, is please let's get rid of waiting rooms. I think waiting rooms represent a waste of space, a waste of efficiencies, because what you're saying is we're not ready for you yet, and you need to wait here. And hopefully in a pandemic world, people aren't willing to congregate in a common space. And so if there's any plea I can make to the group here is, push back on the need for waiting rooms, because you can reuse that space for exam rooms and other useful and productive space that really minimizes the need to wait. And so I guess that would be my sort of my advice and my sort of plea to the group here, to
Sure.
attendees.
Gentlemen, thank you so much. We only have a few minutes left. I do have a question from David Johnson, our keynote speaker from yesterday. Unaffordable care is unavailable care. Isn't the future success and sustainability of American healthcare dependent on a dramatic expansion of the decentralized, low-cost, data-driven, health-promoting business models the panel is describing, right? And an equally dramatic downsizing of high-cost centralized delivery facilities, so that we don't break the bank delivering health and healthcare to all Americans. And I'd like to invite Ron Galloway to join in. He's listening in, and he could pop in as well. I know he's probably got some comments about what we've been discussing so far. So if you could address David Johnson's question as well, that would be awesome.
Well, I'll say, go ahead, Ron.
Oh, hey, can y'all hear me?
Yeah.
Okay. Just a couple of comments. And I hope y'all can't see me because I'm on golf clothes. One thing about the analytics that I thought was highly interesting is that we're running out of doctors. So by 2025, one reason we need analytics so much more now than we did is by 2025, there is projected that we'll have a shortage of around 100,000 doctors. And so if the analytics get advanced enough, they can take up some of that slack. On another point involving rural care, I did the numbers because one day I got sort of interested in it, and rural healthcare facilities are decreasing at a rate over the last 10 years of about 3% a year. All right. And so something needs to take up the slack, and it may just be because somebody like Walmart or like CVS, which is going to wind up having at least half of their 10,000 locations probably be health care locations. Those might become sort of de facto rural healthcare type things. And as far as the connectivity, like I said, Apple earlier this week, putting such an emphasis on 5G, and I can't remember who alluded to it. The satellites going up for internet everywhere. That's the Starlink thing that Elon Musk is doing, which is going to be through fairly soon. That was my basset hound. So I actually think we'll have broadband in places we don't need it. I'm hoping we'll have some sort of facilities to replace the underserved. And I think we've sort of crossed the Rubicon about people caring if their care is delivered, virtually or not, because we're sort of we flipped so quick on a dime to make education virtual that I think people's brains just kind of got used to it. One, I'll say two more things real quickly. It's interesting to me that Epic applied recently for to put more power to their facilities. They almost doubled it, which is kind of interesting when you think that they have a product that in a way is a commodity product. What do they need all this power for? Well, what they need it for is to power all the graphics cards now that are doing all the analytics. All right, so it really is getting to be all about analytics. And Lee, over there at Mass General, I just wanted to ask you if you knew that Mass General is actually the home of the EHR. You had a bunch of guys there in the late 60s, early 70s who invented the MUMPS programming language, and MUMPS MUMPS is exactly what Judy wrote Epic in. It's parts of it are still in MUMPS.
Yeah, we're spreading mumps all over the country, but don't say that.
You should. It's a beautiful language. It's an elegant language. But anyway, that's it. I'm out. I loved listening to y'all.
Thank you, Ron.
I would just say in response to your question, Scott, that we need to figure out how to deliver complex tertiary care in complex facilities at higher cost and primary and secondary care in low-cost community-based settings. We're not a developing country, right? We're a high-income country, but if you look at how we deliver healthcare, we deliver it a lot like a low-income country. And we are, I think it's only aerospace and medicine where innovation drives higher cost, right? So we're going in the wrong direction. And if you deliver a baby at a tertiary care hospital, expense is going to be a lot higher than if you do in a community hospital. And if you're low risk, that's probably not a great use of the space. So we are overbedded in tertiary care hospitals, and we're underbedded in high quality community-based care. But we need a glide path. We can't just shut, 30% of the tertiary care hospitals in the country. Like that's a recipe for disaster too. We need a glide path and a sustainable transition. And it's probably large integrated networks where a single entity can hold assets in each of those components of the value chain. It's sort of like the Benihana business school case. You need a big bar and a big waiting room so you can keep batch processing those expensive chefs to serve 8 people and then move them out and serve 8 people and move them out. We need to own the whole value chain so that we can distribute the care to where it needs to be distributed.
We also need to bring the cost of education for these physicians and nurses down. That's a huge, huge component of it. And hopefully analytics, AI, and other resources can help to shorten that timeline, that time frame for the education and reduce those costs as well. Any last comments, Phil?
So I wanted to thank the whole panel. I thought this has been a really interesting discussion. Thank you for making a conversation rather than just a series of PowerPoints. And I'll hand it back to you, Scott. Thank you.
Yeah, I can't thank you guys enough. This was a phenomenal discussion, phenomenal information. What a fabulous way to wrap up our 3-day conference here. I know we're ready to break open our beers and start drinking. So if you guys got a cocktail
come on
nearby,
over.
You're certainly welcome to join us. At least Dr. Schwab's like, where's mine?
Exactly. Thank you.
Thank you all.
Thanks for including us.
Thank you for including us.
We are very, very lucky and appreciative to have such great minds on one screen and for this audience. And it has been extremely enlightening. So really, thank you.
Deborah?
I thought I'd just pop in here and throw a few
Do you want to
things
introduce
out
yourself?
myself.
Would you like to introduce yourself
I
quickly?
will indeed. So my name is Deborah Gerard, and I am the president of AIA California. And so I wanted to thank you all for attending this virtual stage for our Healthcare Facilities Forum. As you all know, HFF is now in its 10th year, and every year brings new insights and inspiration. And while it's difficult enough to organize any conference, let alone to switch the plan and the formula already in place after years of successful sold-out conferences to go all virtual, doing so took tremendous flexibility and fortitude. And we really have our two co-hosts, Scott McKay and Meredith Turbo, to thank for that. You guys have been phenomenal. You lead this with grace and humility. Your continued leadership in this conference is really incredible, and you've been championing healthcare design and the importance of collaboration for years. You're such great advocates for AIA California, encouraging other members to become more involved with everything that we do as well, not just the Healthcare Forum. And your passion for healthcare is very infectious, and your care for the society at large is extremely commendable. So on behalf of AIA California, I want to thank you. We can't thank you enough for doing what you do, but really wanted to make sure that you two knew how important this was to our profession and to the healthcare profession in general. And we really look forward to doing this again in 2021. So
we appreciate it.
Thank you very much.
But we really want to thank everybody that's on our planning committee. We can't accept. They have so much to do. It is not. We are the talking heads, and they are everyone behind us. As is your team that has been incredibly helpful, and Amy Orr in particular, who I do not know how she did it, but I can just say morning, noon, and night has been working with us and got us through this. So we would like to express our appreciation to them, because we're just the ones you see, but they and your team, our committee, are what make this happen. And
Absolutely.
of course, all of our panelists and moderators and speakers that are doing this pro bono, and we're just damn lucky. That's all I can say. So thank you, everybody. And I would really like everyone to know that you, our panelists right now in particular, are making a big difference in the future of what hospitals and healthcare facilities are going to look like, because this is the information that this community, that this profession needs to understand. It's critical so that when facilities are built, and they will be built in the future, because it does take a while for them to get there, they will be appropriate enough and future focused enough to be able to accommodate what is in place at that time. So it's truly invaluable information. And as I've said before, and then I will be quiet, all of our attendees are making a difference in people's lives by providing the best facilities possible for humanistic and effective healthcare. And as you can tell from our questions, are very focused also on being able to make healthcare equitable and accessible to all populations. So I think that's incredible. And we thank you so much, especially during the times that we're going through.
Well, thank you. And
Thank you all.
I think Ron's Basset Hound said it best.
Exactly. Thank you so much. Thank you, Deborah, for saying what you did. Thank all of you for being here.
You guys are great. Never a more important time for this than now.
Exactly. Yes. With that, we're just going to go party. So thank you. Thanks for the beer.
We're done.
Take care. Everybody is still with us. Thank you. Bye-bye.